Good afternoon. Great pleasure to have you here. I'm with Dr. De Bruyne from Belgium and Dr. Srinivas Kumar from NIC Chair from Hyderabad, India, and I'm Ramesh Dagubati, Course Director for C3. And we had the great pleasure of actually seeing Dr. De Bruyne receive a Luminary Award today on the podium and for his career on FFR. And I would like to ask you, Dr. De Bruyne, how you started your career on fractional flow reserve.
Well, actually, it all started after I met another cardiologist who became a very close friend, namely Dr. Nico Pens. And we were both working at that time on pressure wires, and we developed a means of assessing the gradient into the coronary artery without impeding the flow. And we realized that we were working in an area which was really corresponding to an important unmet clinical need to assess whether or not some stenosis visible on the angiogram were significant and were really, if these stenosis were needed to be treated. So we came together and we decided, which is probably unique in the field of medicine, not to compete, but to collaborate as much as possible. And this was probably the key to success. So basically, we established the fact that it is possible to measure the pressure gradient. We realized that this pressure gradient was actually, let's say, the pressure ratio, the ratio of the distal pressure divided by the proximal pressure was much better than the pressure gradient itself. We also realized that during hyperemia, much more information could be extracted from this pressure ratios. And finally, and this is definitely the merit of Nico Pens, to have demonstrated that during maximal hyperemia, the simple ratio of distal pressure divided by proximal pressure corresponds to a ratio of two flows. So it is important to realize that fractional flow reserve is actually a ratio of two flows, but which can be measured by simple pressure measurements during maximal hyperemia.
Dr. Srinivas Kumar, what do you think about the new study that has shown that stenting is being done unnecessarily, and I think a sham procedure similar to renal artery denervation has been done in coronary angioplasty era, and Orbiter is the name of the study. Can you please expand on that?
The basic problem with the Orbiter study, I would feel, is as elegantly told by Brian, which subset of patients you're dealing with is also important. If you take a patient subgroup in which they are likely to benefit by revascularization, like if you have about 1/3 of patients who had FFR values later when they were thought were not significant, that is, had more than 0.8, obviously they are less likely to benefit by some sort of any revascularization. So which subgroup of patients you are dealing with, I feel, is very important. And if you have taken a subgroup like FAME study, which is FAME 2, in which patients who are having significant lesions hemodynamically, less than 0.8, which was taken as a cutoff, is taken, and then revascularization is done, and then they are studied, I would feel definitely they would benefit. Courage, which was earlier studied, had about 2/3 of them who had hemodynamically non-significant lesions. The Orbiter is not that bad, but about 30% of them had patients who are not having hemodynamically significant lesions. So obviously, when you take a lesion subset which is less likely to benefit, you can't prove the benefit of stenting. That is the main flaw, I would say. And other things are, what was calculated was very short-term exercise capacity, though it was thought to be slightly improved. It can be definitely proving everything about revascularization. We need more long-term data to see whether the mortality patterns and the recurrent MIs events which are happening, would it be different between the two subgroups. So that is why any trial, don't take it on the face value of it, but you try to see what are the basic patient subgroups which were taken for the procedure and study.
So coming back to you, Dr. De Bruyne, you have said that FFR, the gradient before and after the blockage can predict events. These events short term or on long term, and as we saw with Orbiter, the short term it may not improve, but do you think the same thing goes with the fractional flow reserve?
Well, yes, again, the fractional flow reserve is not only the ratio, but really the not only the pressure gradient, but the ratio of these distal pressure divided by proximal pressure. And to allude to answer the second part of your question, yes, definitely the FAME2 results became really important once we started following up the patients after 3 years. It's really after 3 years that you see the big differences occurring between the patients treated with medical therapy only versus the patients treated with drug-eluting stents. After 3 years, we have seen not only an increase in the number of urgent revascularization in the patients with medical therapy as compared to stenting, but also a very strong signal towards a significant difference in terms of myocardial infarctions. And even more, the myocardial infarctions were not these relatively small periprocedural MIs. These were the spontaneous MIs which happened late. So that's very important. So not only urgent revascularization, when you follow the patient long enough, also MI come into the picture. And that's of course a hard endpoint. That's really very important to prove finally that even in patients with stable angina, that's the first time we have a clear benefit of stenting when done appropriately in selected patients, selected lesions over medical therapy.
That's very important because people criticize FAME2 saying that if you tell somebody you have a 80% blockage, obviously everyone starts feeling that chest pain after knowing that they have a blockage, and they come back into the hospital for urgent revascularization. But as you said, it's not just urgent revascularization, but even spontaneous MIs were reduced by FFR-guided PCI rather than optimal medical therapy.
Yeah, I would like to add that you are speaking of telling the patient that he has a blockage. You're right, but we have a registry group of patients in whom there was also there were also stenosis. These patients were also told they had a blockage, but they never came back to the hospital for urgent revascularization, or at least much less often than the patients under medical therapy in whom there was a significant stenosis. So the fact of not having blinded the patients to the presence of a blockage is really a criticism it's a weak argument to criticize FAME2. It's a very weak argument.
Dr. Brian, what is your opinion about usage of FFR? In India, we do see a lot of young ACS patients. We have sometimes branch vessel disease and the disease in the non-concrete vessel. So we started using this technology even in that subgroup. But there is some criticism in saying that in acute setting there could be difference in microvascular resistance and stuff like that. And the same thing may not be applicable. What are your thoughts on it?
Well, I think we have to be very clear. In cases like you describe, patients coming in with an acute coronary syndrome and multivessel disease, which means one culprit lesion and one or two or three non-culprit lesion, well, provided you exclude the massive myocardial infarction and the patient in shock, which is common sense. In all the other patients who are stable, I think fractional flow reserve does apply. And all these stories about microvascular dysfunction, which might acutely change in the contralateral vessel, have been overstated. We have very clear data supporting the fact that when you measure fractional flow reserve in the non-culprit vessel during the acute stage, you don't do anything to this patient, but you bring them back to the cath lab 6 weeks later, the fractional flow reserve in that non-culprit lesion will be exactly the same. So practically it means that you might base your decision on the fractional flow reserve value that you have measured during the acute phase.
Okay. One more thing which bothered clinicians as well as patients is the usage of this FFR wire. So obviously it is not as user-friendly as a routine PTCA guide wires. You need to apply a little more caution in dealing with it because it has a transducer and slightly more risky in handling. Sometimes we could avoid patient get dissection, things like that. So we were always trying to see for an entity which you could get a similar value. We call it as QFR or angio-FFR, where you get angiographic 2D reconstruction of the pictures gives a value, a computer algorithm. What are your thoughts about those so-called non-invasive FFR obtained by this Q-angio, or now we call it as QFR?
Yeah, that's a very good point. Well, first, I think that the presently available pressure wires, and there are several vendors on the market, are very acceptable. If you are a little bit careful, if you are used to it, they behave really almost like a regular wire, a workhorse wire. Now, coming to your second point, indeed, it will remain more easy for some investigators, some operators to use the information obtained readily from the angiogram. And this indeed is now available or is starting to become available under the form of the QFFR, the FFR angio, which is a translation by 3D reconstruction of the model of the coronary circulation, which ultimately down the line gives you a 3D reconstruction and color-coded of the entire coronary tree that you can have on your boom next to the regular angio. So the information is derived from the angiogram. You don't need hyperemia, you don't need a pressure wire, and you have the color-coded FFR values on the coronary tree. And of course you can play with the coronary tree and you can take your decisions on the basis of an, let's say, of an angiogram, but added or enriched by color-coded FFR.
So what about CT FFR? Coronary CT FFR, do you think that has a role in the future? In your opinion, where is it going and how can we use it?
Yeah, well, there I will be very straight, maybe a little bit too straight. I definitely believe this is the future. This will replace all non-invasive testing as frontline non-invasive testing in patients with suspected coronary artery disease. We have used that since many years now in ALS in our department. There are a couple of centers starting using it. This is incredibly precise, provided the quality of your CT scan is optimal. And that is, of course, extremely important. You need a real collaboration between the imaging people. I would say in some centers these are the cardiologists, and in other centers these are the radiologists. Sometimes there is a collaboration, but the CT imaging should be optimal. And once the CT imaging is optimal, you get excellent quality of the data. Not only you have the 3D reconstruction of the coronary tree, but exactly like I just mentioned for QFR and FFR angio, you have a color coding of the FFR superimposed on the coronary tree. And this is fantastic because this is completely non-invasive, and this really is a shortcut to the cath lab, or a very good gatekeeper from the cath lab, I would say.
Latest Syntax 3 trial, which was done by Patrick Serras, showed these two subgroups. Yeah. One was taken, diagnostic evaluation was done by CT FFR, and then decisions were made out of it. Other was angiography, a regular angiogram was done, and then patients were taken for decision making. In 1 year outcome, they showed that both are equally good, and it did not differ. So in future, if it works out well, that could be a good evaluation for at least for coronary artery disease, non-invasive.
What do you think about the FAME3? Where is it and how is it proceeding now?
Well, FAME3, very briefly, is a multicentric randomized trial comparing FFR-guided PCI in 3-vessel disease versus CABG in 3-vessel disease. It is led by the PI. The PI is Bill Fearon from Stanford. We are recruiting a little bit slower than expected. It's a difficult study because, again, a little bit like ARTS a long time ago, or like Syntax, more closer by in time. We have to explain to the patient that they will be randomized between PCI and surgery. It's not very easy to obtain that from the patient. That's the major hurdle in all the centers. But this being said, we are approaching the end of the recruitment of the patients, and I expect to have the first data published, which will be the 1-year follow-up by the end of 2019. That will be probably the first date where we will have some information about the trial. The trial is a non-inferiority trial, trying to demonstrate that indeed multivessel PCI with drug-eluting stents guided by FFR is non-inferior to CABG, classical CABG. In the CABG arm, FFR is, let's say, not advocated. I wouldn't say not allowed. When the surgeons request it, they can have FFR, but then the patient has to come back to the cath lab for these measurements. But it is strictly FFR-guided PCR versus classical CABG, as is still done in 99% of the centers.
So it's pretty similar to ischemia trial, where there is also a segment of patients do have FFR?
Well, yes and no. Well, here we are not comparing medical therapy and PCI, but we are comparing really two strategies of revascularization. All the patients will be revascularized. Again, one part of the patients guided by FFR and with regulating stents, the other one with CVG.
Dr. Srinivas, in US, the usage of FFR is still not more than 50%. At the most, it is probably 20 to 30%. We like to think it's because we are recommending stress tests, and every patient coming into the lab is having a stress test and stable angina. I hope that is true. But in India, what is the penetration of FFR?
Same thing, FFR usage is something like 15 to 20%. The NIC data showed a usage of about 16% of diagnostic procedures. Though it is said that it is less expensive, but still any diagnostic procedure in India, the challenge is if it costs more than a stent, obviously stent prices have come down, then patients wouldn't like to spend that. But I would definitely say to take this criticism of avoiding unnecessary procedures and not doing stenting for not required lesions is a great thing which is possible, and we should be thankful to Brian and others for developing this technology for the patient well-being. And definitely we now know that when we are doing it, we are doing the right things to patients. The other beauty of this procedure is after stenting, if you check again FFR, sometimes we do the procedure with the same wire. After stenting you do it, it becomes like 0.99, 0.95 to 1.0. There are some studies showing that again if the outcomes are more than 0.92, results would be better. But that gives really heartening to note that this is a really good technology where once the stenosis is removed, the values are becoming totally normal. That is an immediate table demonstration. Sometimes we feel good about it, and though utility is less, I would feel it more and more patients can take the benefit of this technology.
So are there any subsets of patients that you think FFR may not really work? Left main, bifurcations, or serial lesions?
Well, there are three subsets of patients. Those in whom we should not use FFR, and these are, for example, patients with massive left ventricular hypertrophy. To evaluate bridging, that's really the last thing to do, is to try to evaluate that with FFR. And some patients with acute chronic syndromes, especially in the culprit lesion, it doesn't make any sense to measure the fractional flow reserve if you're really sure that you identify the culprit lesion. That's sure. Now, in all other subsets, it is useful or it is applicable, it is valid. Now, this being said, it doesn't mean that because it is valid you have to apply it. And for example, in bifurcation lesion, in my opinion, the use of FFR has been overstated and have been pushed a little bit too far. I think to evaluate side branches, it is not the right thing to do. You are making things more complicated than they should be. To evaluate whether a big diagonal branch is significant, yes or no, that is another thing. You can do it before that. But for example, to evaluate whether or not the pinching that you have seen after stenting is significant, yes or no, that's not a good strategy. That's not a good case subset of patients and lesions in which you should use fractional flow reserve. Fractional flow reserve should be kept simple, simple, simple. And we should not use fractional flow reserve to make cases more complicated.
And you're absolutely right. DK Crush 6 study looked at FFR guided versus angio guided treatment of the side branch. As you mentioned, pinching of the side branch ostium. It didn't make any difference.
Yeah, but yeah.
It's a negative study.
Yeah. I'm not surprised.
What are your thoughts and precautions to guide the listeners to be taken for ostial left main and ostial RCA lesion calculations for FFR? Because there's no place proximally. Can you tell your thoughts about how to take the proximal pressure?
Yeah, we are entering into very practical details, but you're right. Ostial lesions are a little bit more complicated practically to measure. I would say do as regularly. You go into the ostium, you put your wire down, you try to equalize a little bit more proximal to the ostium, which means very often in the guiding, it's not a big deal. Then you put your wire down and you induce hyperemia. Very often it's easier to induce hyperemia with intravenous adenosine, but if you use, for example, intracoronary papaverine, which is extremely cheap and which lasts during 1.5 minutes of steady state hyperemia, you have ample time to put the wire down, give the adenosine calmly, disengage the guiding, and just watch at the screen what happens. So it is so simple when you apply it simply.
You meant intracoronary papaverine?
Yes.
That's given, okay. So how about normalizing in the aorta? You normalize in the aorta?
Well, when you have a real ostial left main or real right ostium stenosis, you have, of course, to equalize proximal to the lesion. Actually, the concept of equalization is asking the machine, the computer, to make sure that both systems speak the same language. So actually, where you equalize is not that important, provided that the sensor of the wire and the end of the catheter are located in close vicinity to each other.
How did you enjoy C3? Any last words?
Well, C3, it's the first time I came. I'm very fortunate to have been invited. Thank you very much for this. I discovered a small-sized meeting, I would say human-sized meeting, very interactive, very vivid, with a very nice program, very educational, so very high quality of the session, so I enjoyed this very much. Thank you very much.
Thank you very
Nice
much.
Orlando to enjoy.
And a nice weather.
Thank you. Thank you very much.
Thank you.
Thank you, sir.
Thank you. It was nice to meet you.
Thank you.